a rhinoplasty surgeon practicing in Athens. Thank you, George.
You are welcome. Good afternoon, ladies and gentlemen. I'm really happy to see all the seats already taken, because after almost 2 years of absence, it's something really good to see. Okay, I'd like to start by saying thank you to the organizing committee, of course, personally to Yannis, to friend Yannis, for this kind invitation to participate on this very interesting round table. Okay, let's move on. I don't have anything to disclose. Let's start with the case. It's a primary functional rhinoplasty. It's a young lady, almost 20 years old. She came to me complaining about some functional problems and some other issues. I'm going to show you exactly. You can see on the lateral view, her complaints is the nasal hump, the droopy tip, and of course you can understand that the tip support is not very good, especially when she smiles. Same picture on the other side, and from the frontal view we can also add that the middle third is a little bit narrow. This is her pre-op 3D simulation, and our primary goals was the tip rotation and of course the elimination of her hump. I'm going to show you a kind of modified technique of mine. This is the first step, is to produce something that I called it a hybrid cup. I'll explain you later why I called it something like this. This means that it is a cup, not a bony cup only, but cup with bones and cartilages. To understand it even better, this is pictures taken from Palhazi et al. Palhazi demonstrated that very well that our dorsal area is comprised by two portions. The first one is the covering bony cup from 0.5 to 0.5 millimeters in depth, from 0.5 to 1 millimeter. That bony cup covers the real hump, which is the cartilaginous hump. Okay, and in my modification, I am trying to produce this hybrid cup. Let's start with the standard preservation osteotomies. You can see the standard preservation osteotomies. And these are the hybrid cup osteotomies. These osteotomies produce this floating, kind of floating hybrid cup. It comprises, as I already told you, by the bone and the cartilaginous vault, a part of the cartilaginous vault, meaning the upper lateral cartilages and, of course, the septum, the upper part of the septum. These are some enhanced hybrid cup osteotomies. This means that I usually remove some more of the bony vault. Okay. I put this image here to remove, to go to the next step, which is I usually use the Tetris concept by Jose Carlos Neves. I liked it very much, but of course you can do my modification in combination with other techniques, which is the technique of Tetris. We start with the cephalic cut, then we made this caudal cut. This is the horizontal. We go then to the superior horizontal cut. This is under the bone vault. And after that, by measuring exactly how much millimeters do we want to gain by pushing downwards our hump, we remove the exact size of a triangular here of the exact size. This is what we excised already. And then we produced this, the cephalic triangle. This contains parts of the septum and the PPE. And of course, we've got to design this small caudal triangle just not to make any trouble during the movement. Then we start with a cephalic suture here and a caudal suture. And by placing these, you can use 5/0, 4/0 PDS or Vicryl. I think Abdul Qadir is on the idea of first using some Vicryl 5/0 and then some PDS 5/0. And this concept gives us this downward and rotation of this Tetris. You can see in comparison the animation here, and this is the surgical video. When I push downward this Tetris, and after this mobilization I performed with our bones, you can see the movement of the hump. And this is the surgery. These are from a specific case. In this case, just because we want to have access on this area where we are going to perform these modified osteotomies, we perform, of course, a semi-extended dissection, and then I had to remove everything that was blocking the airway. This is everything that I removed from the septum, just to make it straighter. And here you can see these osteotomies. You can see you can perform this, of course, under direct vision all the time. You don't have to go with a full degloving. You've got to have only a narrow strip just to be sure that you can use the irrigation, the water irrigation. It's very easy to do it with these tiny angulated tips of the piezo. And after that, I had to make it a little bit extended just to secure a better downward movement. Then was the time for the Tetris cut. We mark with our needle the upper part of the hump. This is the first cut. This is the second, and this is the horizontal cut. You can see this small triangle. I show you I showed to you earlier. This was from cartilage, and this is a even smaller part of bone, the perpendicular bone. And you can easily see this the movement of this new unit we already produced. It's really impressive, I could say.
Πέντε.
Ναι, ναι. Ωραία.
Some sound. After that, after being ready for the suturing, I would recommend you to place about 3 sutures, not 2, just to be sure, and 4 is even better, I think. And of course you can use piezo for smoothing after all this bony work. In this case, just some other tip work. I used slide adder. I cut the cephalic part. I usually do not throw it away. I usually use turn-in flaps, but in this case I prefer the slide under. The cephalic part, of course, under the caudal part. Okay. And it was the time for the septal extension graft placement. After that, I had to fixate it to the anterior nasal spine. I think that you've got to pass 2 times to secure it all right. And after that, the LLC is answering to the septal extension graft. It's a tongue and groove movement and a tip graft. And the results, you can see from the left side that we are okay with 3 problems. The nasal hump, you can see it's pre-op, 6 days and 2 months post-op. You can see that the nasal hump is gone, the droopy tip is gone, and of course the bad tip support is gone too. It's much easier to see that the support is very good when she smiles. And it's the same on the right side. And on the frontal view, you can see that the narrow middle third is already addressed. And I would like to highlight that you can see how natural are these curves. It's not, you cannot see 2 straight lines, because it's okay to have 2 straight lines, for example, like after placing spider grafts, as I recommend in Peter's case, but of course these curves are much more natural to go after them. The pros and cons, I think that with this modification you can have, of course, ultra-natural results. It's easy and quick procedure. You can, of course, avoid the complete mobilization of the bone structure. That, of course, it's something that goes along with the standard preservation rhinoplasty, and of course, avoiding the risk of collapsing the whole structures after after having complete, for example, low to low lateral transverse or whatever suits you better in your practice. In this case, you can, with these osteotomies, you can have access to some local deformities of the dorsal area after, of course, this narrow dissection, and of course you can have a slight internal valve opening. The disadvantages could be, I could say that the dissection of this narrow dorsal area, of course, is a disadvantage comparing to the standard preservation rhinoplasty. It's not exactly preservation, but okay, we can have a kind of compromise on having all these pros and to have to dissect only a narrow dorsal area. Of course, to follow this technique, you've got to have the piezo device. And I have some question marks because I'm performing this kind of modification for about 3 months now only. I have about 15 cases. I'm okay with the results so far, but of course I cannot say something more when I will try to use it in crooked noses and of course in some secondary cases. This is the end of the presentation. I hope you enjoyed it.
Thank you very much, Dr. Mireas. Any questions from the floor? Can I ask you guys, how many of you are familiar with preservation principles? Because Dr. Mireas got into a lot of detail. Are you all familiar, and have you heard lectures about preservation, and are you doing preservation? Okay, let's see. How many of you are still trainees? Okay, and how many of you are practicing? Okay, the majority. How many of you are doing preservation? Okay, some hands up. Great. Okay, good. So, because we have the way this round table was formed, we thought we will present cases and keep it interactive. So there is no theoretical presentation on preservation. So all I'm going to say to help with some questions that you might have is that in general, preservation has been classified by Roland Daniel into surface techniques and into impact techniques. So this was a surface technique, okay? It was the action was on the surface of the nose. And the impactation techniques is when we do push down, let down. So we're actually fracturing at the base of the nose. That's all I'm gonna say, because of course I can't do a lecture on preservation exactly. Well done, Dr. Mireas. I liked it a lot. And as far as I understand your modification, it's actually, we call it, if that suits you, bony cap osteotomies. Is that something similar to? Yeah.
Something like this.
Baris Chakir talks about it. I don't remember now which chapter of the preservation rhinoplasty book, and for any of you that need more information, is very nicely written, the 3rd edition. And you can find all techniques there. Maybe you'll get more confused at the end, but it's always difficult when we change concepts.
It's a good start.
I have a few questions. I wanted to ask you, very nice demonstration. I enjoy everything, the 3D, your videography in the beginning. You'll see that videos gaining interest in rhinoplasty, and we present cases now with little videos instead of just static photography. I wanted to ask you this. Did you actually do any dissection at the level of the piriform ligament? Did you do any ballerina maneuver? Did you have to dissect there, or not at all? You had?
In most
that I didn't see.
Case, about, I would say, in about, let's say I had 15 cases, I performed ballerina maneuver in 12 of them, out of them.
Okay,
because
so
I can avoid ballerina maneuver if the whole structure the movement of the whole structure is okay with the final result. But in most cases, you've got to cut the hump in two pieces, a cephalic and a caudal one.
That's right.
This means that you've got to release the lateral walls with ballerina maneuver.
Excellent. So what Dr. Mireas was doing was not removing the hump, he was stretching down the hump. And that is what we do on surface techniques in preservation. And you saw that beautifully because every hump, as we know, has an osseous component and a cartilaginous component. So the cartilaginous component was dealt with this Tetris concept. So he removed that piece, and then he went under the bone and removed a little bit more. And the bone component, the bony cap, had some osteotomies just lateral to it, and the whole thing came out with complementary dissection between upper lats and piriform aperture. You need to create space for this thing to go down, because it's like that, and it's going to go down like that. Another question I have, when you removed that perpendicular plate, how did you do that? With what instrument? I didn't quite, how do you do that?
With strong scissors.
The ronger?
No.
With a true cut?
Yeah.
Blakesley true cut?
Yeah,
wonderful. It's a nice instrument too, and it's delicate, and it's small. If you take the 2-3 millimeter, actually you can go under there, and isn't
but
it?
If it is strong, we've got to maybe to use something else, or a piezo. It's very difficult.
Yeah, I thought you were going to say piezo, and that's why I asked the question.
It's a tip problem.
Yeah, it's too little space for even a piezo insert, isn't it? Yeah, and that's true that the Blakesley True Cut, for those of you that want to go into that area, works really, really beautifully there, because it's a tiny instrument. Any questions from anybody? Yes, please. Yes, please.
I think I have seen this similar technique in Ishida's publication about the bony cap. My question is about if you use CT scan or cone beam before surgery to address the shape of the bony cap. Because in this case, it was like easy to see that it was a V shape, but when you have an S shape, this technique, maybe it's not possible because you have to remove all the bony cap in order to flatten the hump. Do you usually perform CT scan pre-op?
No, it's not something in my original private practice to send the patients for a CT scan. Some of them can go for cone beam CT, but I think that if you want to be aware of the shape of this area, you don't really need a CT scan. You can palpate and find out if it is S or L shape. You can do it. But of course, the main problem, and you could face and send your patient for a CBCT, is not this area, because I could say that this area is comprised by really thin bones. It's very difficult to see so many irregularities on this area, the surface of the bone. Of course, you can use CBCT in the standard preservation rhinoplasty. It's very useful. But I don't think that this area in this area you can have a lot of more information that could lead you to follow another way.
And I think about the comment you made before, Peter, about the release of the lateral keystone area from the piriform aperture. If you have a big hump, you have to release a lot.
That's
and
right.
That makes unstable the structure, and it's also more possible to make irregularities in the dorsum.
To make?
And something irregular, like a little step or something that you have to camouflage later. And also I wanted to ask you that about the, in this case you wanted to widen the middle third, but if you have a case with a wide middle third and you want to perform this technique, do you think, how would you do for preserving dorsum but not widening the middle third? Would you perform a low strip, for example, instead of a Tetris concept?
But this is not a modification for everything. You got if you want to change the shape of your whole structure, of course you are not going to follow any superficial technique.
I think, can I add to that? I think this is a contraindication for preservation. If you had wide dorsal aesthetic lines, you need to, more often than not, you need to remove a little bit of bone, and I wouldn't advise you to do preservation on that.
Well, some people.
And about the cone beam, I do actually have some cone beam on my talk because I think it gives you complementary information. Perhaps the shape, as you said, it's important that not all nasal bones have the same shape. So if you're going to do any preservation and either preserve the bony cap, you really need to be aware of the shape. Of course, clinical examination will help you, and if you open the nose and you look, it will also give you an idea. But without a doubt, if you have an S-shaped bone, it needs a lot more work. You need to actually take that bone down caudally, almost remove the bony cap in order to change the S shape into a V shape, and then proceed with whatever technique you want to proceed. The other point about the cone beam, which is almost, in my opinion, indispensable for preservation, is that you see exactly where the E point is. The E point is where the perpendicular plate of the ethmoid starts exactly underneath your nasal bones. And how long is that piece? Usually there is a study by Miguel Ferreira done and published, I think, Laryngoscope, where it shows that in 94–95% of the cases, the E point is at a more cephalic position to the rhinion, but sometimes, in very few cases, this E point is more caudally, and this you need to be aware of because you're going to instrument in that area. So as much as I would love the approach that, okay, maybe it's not really necessary, I find that it gives you some complementary information, especially for beginners in that area, because you all of a sudden you're doing things. You're doing actually things that are almost contrary to what you've been taught. And that's, I think, the tricky point about preservation, that all of a sudden it's, you're doing structural, and all of a sudden you're going against things that you have been taught and perhaps trained and perhaps performing for years. Any other questions?
I would like to
please.
say a comment on this. Filio is talking about this, the cephalic triangular, because it's very important to be safe in this area. Of course, if you are an experienced ENT or plastic surgeon, you've got some other solutions and you feel more comfortable. But I would like also to add that in this, with this modification, you can actually see the shape of the bones, because you operate under direct vision first, and the second is that you can kind of modify to remove not the bony cap completely, but of course to modify a little bit the upper part of the bony cap and make it suitable to continue with these modifications of these modified osteotomies. Of course, if you feel after the dissection on this area that this is not going to finally work for you, of course you can make it something totally different. or a standard preservation rhinoplasty, or even a classic standard piezo or open rhinoplasty. You can do it. You can change your plans. You are much flexible on this.
Are you planning to use your technique for a crooked nose?
I don't feel very comfortable now, but maybe. I'm not so sure. That's why I put the question marks in front of the crooked nose. But I think that I'll let you know maybe in another congress in the future.
But I think as a comment to your question is that for the deviated nose, invariably we have to do osteotomies at the base of the nose, and invariably these osteotomies are not the same one side to the other. So I think it's really difficult to straighten a crooked nose just with this. Maybe it's feasible. I don't want to say it's not. I just find it difficult to figure it out. But maybe Dr. Mireas will enlighten us on that technique in the future. Any other question?
I think, Filio, it's time for your presentation.
Thank you. Thanks again. It was a great presentation, Dr. Mireas.